Hello everyone, I'm Rashidian. I'm a PhD student at the University of Toronto and I'm currently conducting research on access to care for diabetes. So now we're going to focus on diabetes and see what OHTs can learn from the data that is provided to them using diabetes as an example. So we will be looking at 5 specific diabetes related indicators, which are listed here on this slide. So the first 3 of these indicators, patients up to date with HbA1c screening, patients that are up to date with retinal examinations, and patients that have had statins dispensed, these are related to diabetes management at the population level. They're not outcomes per se. And the last 2 of these indicators, we have hospitalization for long-term diabetes-related complications and proportion of patients with HbA1c levels greater than 7, meaning that their HbA1c is not under control. These 2 are outcome indicators, and they show us how patients are doing overall. So we will be looking at all of these indicators using an equity lens. And the marker of equity that we will be using is the Material Deprivation Index, which is based on Canadian census data from 2016. Basically, what this does is it looks at things like income, educational level, housing quality, and family structure. And it's closely related to poverty, it's related to access to care and patient health outcomes. And this data is split into quintiles. So in the Q1, which is the bright green, we have our least deprived neighborhoods, all the way to the Q5, which is the most deprived neighborhoods in the dark blue. So in this image, which is based on the most recent year of data, we can see all our OHTs stacked. And at the top, we can see that we have some OHTs that have up to nearly 40% of their population in most deprived areas, while at the bottom, this is less than 10%. So now let's look at prevalence of diabetes across OHTs and see what we can learn when data is presented in this way, which is the format which is used in the HSBN reports. So here we have prevalence of diabetes across OHTs based on the most recent year of data. In the top panel, we can see there are lots of colored dots. Each colored dot represents an OHT, and these have been sorted. So on the left, we have more desirable values, which in this case is lower prevalence of diabetes. Moving on to the right, we have less desirable values. And the way that these have been colored is OHTs, which have a higher proportion of their attributable population living in least deprived areas, are light green, moving all the way to those who have high proportions in most deprived areas in the dark blue. And the dotted line in the top panel represents the average across Ontario. So with the prevalence of diabetes, meaning the proportion of our population over 18 who have diabetes, we see that the average across Ontario is 13%. This ranges from around 9% to 16%, which is an almost 2-fold difference across our OHTs, showing that this shows that we have high variability. And you can tell here with dark blue dots that they're clustered more towards the right, which means that there's a correlation with deprivation, a correlation of 0.5 to be exact. Moving on to the bottom panel, in this panel, we're not looking across OHTs, we're looking within OHTs themselves. So what we do is within each OHT, we look at the most deprived subgroup of the population and the least deprived subgroup of the population, and we compare the measure we're looking at, in this case prevalence, to see how they're doing. So if we have similar rates of prevalence in our most deprived and least deprived subgroups, the ratio of this would be 1 and it would fall on the dotted line and we would have equity. But if the dot falls above that dotted line, then it means that we have higher prevalence in our more deprived subgroups. So in this case, you can see that all of our OHTs fall above the dotted line. This means that we have higher rates of diabetes prevalence in our more deprived areas within each OHT. Now let's look at how these diabetes indicators have changed over the past 3 years, particularly since in 2020 we had COVID-19. So on this slide, we have our 3 population management diabetes indicators. So we have the HbA1c screening, we have the retinal screening, and the statins dispensed. So if we start off with HbA1c screening over here on the left, you can see that in 2020 compared to 2019, there was over 10% drop in the proportion of our patients that were up to date with HbA1c screening. In 2021, this has recovered somewhat, but it's not yet at the level that it was prior to the pandemic. Another thing that we notice is that across the different income quintiles, the different colored columns, they seem to be doing relatively the same. There isn't a gradient that we can observe just by looking at this data. Moving on to retinal screening in the middle of the screen. So again, we see in 2020, we have a drop compared to 2019, and this has continued to drop in 2021. When we look across quintiles, we see that Q1 through Q4, they seem to be around at the same level. There's a little drop in Q5, but again, this isn't a strong gradient. Moving on to the proportion of patients with diabetes that have had their statins dispensed on the right, we can see that over the course of these 3 years, this proportion has remained relatively stable. And again, we don't have much difference between our different material deprivation quintiles. Here we're looking at our two diabetes outcome measures. So we had the proportion of patients with good control and poor control, and patients that have diabetes-related long-term hospitalizations related to long-term diabetes complications, such as amputations, blindness, etc. So if we start off with diabetes control on the left, we can see, first of all, the thing that comes to mind is that here we have that gradient. We see that the proportion of patients with good diabetes control is higher in Q1 in the low deprivation group across all 3 years. Conversely, we see that the patients with not good control are higher in our high deprivation groups across all years. And again, we notice that the proportion of patients with good control has dropped, and also those with not good control has dropped. So this might seem counterintuitive at first, but basically what it means is that the proportion of missing data has gone up. This aligns with what we saw in the previous slide, meaning that fewer people got their HbA1c tests done during COVID. Now let's look at the hospitalizations on the right. Just one thing to take note of, that the range here is between 0% and 3%, so it's not a huge range, but still, when we look at the data, we have a strong gradient, meaning across all 3 years, hospitalizations were happening at higher rates in our more deprived groups. But over the 3 years, the hospitalization rates does not appear to have been greatly impacted by the pandemic. Now we'll look at each of our diabetes indicators separately. So here we have the proportion of patients that are up to date with HbA1c screening. This is diabetes patients over the age of 40 that have had at least 2 HbA1c tests within the past year. So the average for this across Ontario was 47%, but this ranged from 30% to 56%. So again, almost twofold difference across our different OHTs. There doesn't seem to be clustering of the dark blue. We have a weak correlation with deprivation. They're not clustered to the right or to the left. And here, when we look at the bottom panel, we can see that most of our OHTs are on or very close to that dotted line, meaning they're close to that ratio of 1, meaning we have equity. The proportion of patients that are up to date with their screening is the same in our more deprived and less deprived subgroups. Here we have patients with diabetes over the age of 40 that are up to date with their retinal examinations, meaning they've had at least one retinal examination within the past 2 years. So the average for this was 61%. This ranged from 55 to 71%. We have high variability across our OHTs. There is no clustering of the dark blue to the left, so we have weak correlation with deprivation. And when we look down at the bottom panel, they seem to be nicely laid out along that dotted line, which is indicative of equity. We have the same rates of retinal examinations in our more deprived and less deprived groups. This is the final process indicator. This is the proportion of patients with diabetes over the age of 65. So this is based on the Ontario Drug Benefit Program that have had statins dispensed within the past year. So the average for this was 72%. This ranges from 61 to 76% across our OHTs. We do have a couple of outliers here on the right, but if we take those into account, we have high variability across our OHTs and a very weak correlation with deprivation. Our dark blue OHTs are scattered throughout the image. And when we look down at the bottom panel, they're all on the line. This is indicative equity again, so patients in our more deprived and less deprived groups within our OHTs are getting their statins dispensed at the same rate. Now we're going to look at our 2 outcome indicators. So this is patients with HbA1c levels greater than or equal to 7, meaning that these patients are not in good control of their diabetes. One thing to note is that with these outcome indicators, this slide and the next slide, the findings have been risk adjusted based on age and sex. This allows us to better compare our OHTs. So the average for this was 38%. The range, that means that 38% of our patients are not in good control. So this ranges from 31% to 57%. Again, almost a twofold difference. We have high variability across our OHTs, and the dark blue dots are more towards the right, where we have fewer of them on the left of this image, which we have a weak to moderate correlation with deprivation, a correlation of 0.3. And when we look down at the bottom panel, most of our OHTs fall above that dotted line. What does that mean? That means that patients with poor control are more likely to be found within our more deprived neighborhoods within our OHT. And on to our final indicator, hospitalization for long-term complications. This is a proportion of patients with diabetes over the age of 18 who have had at least one hospitalization for a long-term diabetes-related complications such as amputation, blindness, kidney failure, etc. within the past year. The average for this was around 2%, but this ranged from 1.3 to 6.2, more than 4-fold difference. However, we do have an outlier here on the right, as you can see, but when we take that into account, we have high variability across our OHTs. And moving down to our bottom panel, you can see that they are definitely not sitting along the line, and almost all of our OHTs are above that 1% line, meaning that patients are getting hospitalized in more deprived neighborhoods at a much higher rate than they are in the least deprived neighborhoods. So to summarize, what we see from the data is that overall diabetes management is moderate. 47% of our patients are up to date on their 2 HbA1c tests within the past year, 61% are up to date on their retinol screening, and 72% have received the recommended statin therapy. And what we saw, if you recall, we had a high degree of equity in these three population management, the screening indicators. But what we did see is that there were inequities in our health outcomes associated with diabetes, meaning that patients from more deprived neighborhoods had high hospitalization rates for diabetes-related complications, and they also had high proportions of HbA1c levels that were greater than 7, meaning that their diabetes is uncontrolled. So overall, in order to achieve diabetes management in our population, we will require new strategies to reach those individuals who are not up to date with their diabetes management. It's vital that patients access care, but we must make sure that the care that they are accessing is effective. And also, there's likely more to reducing diabetes complications than just diabetes management. Social determinants of health likely play a role in this, and diabetes management at the population level will require coordination across our different healthcare sectors. More research, my PhD thesis will look more carefully at the drivers of good and poor diabetes-related health and hospital outcomes.